Okay. Okay, so you guys probably recognize most of the names here. We also have included our site leads and our steering committee, which were some sort of advisory faculty members that helped us in the trial designing. So, okay, so this is the sort of brief outline of what we're gonna go over today. A quick reminder of some of the research modules that I believe Annie, our research coordinator, had emailed to everyone. We're going to go over the responsibilities that you guys have, remind you of some of the study objectives and outcomes, and then we're going to get into sort of some of the nitty-gritty of what actually happens when patients are being recruited, what are the actual details of the protocol, what happens after the recruitment, and what sort of timeline we're looking at. And then at the end, I know we had discussed authorship policy. I'll just remind you guys of some of those details, and then a link. We have a document that we can send you guys. I believe you guys have all seen that at least once over already. Okay, and then hopefully we'll have some questions to be answered. Okay, so this probably looks familiar in your email from Annie. So these are just a couple U of T training things that all of us have to do for a clinical trial, including myself and Keith and Brian. Once you complete everything, it probably takes about an hour or hour and a half, depending on if you've done them before or not. And once you complete those certificates, you can send them off to Annie. We need documentation of this being completed before we're actually able to start any of the Health Canada stuff. If you guys haven't received this email or have lost it or anything, just send us a message and we can forward that on to you again. It's no problem. There is some additional training that Annie wanted me to point out that's not sort of as immediate, so to speak. So we're going over some of the study protocol version 4 at the moment. That's part of today's talk. There's going to be a standardized informed consent document that will be posted on sort of our share file that we'll all have access to. And then we'll talk a little bit about that today. There's a very in-depth manual of procedures, which sort of explains everything in more detail that we're talking about today that you guys have as a resource, as well as sort of a truncated version or synopsis version of that. We're going to go over some of the electronic data capture, and that's going to be done by Keith today. And then there's some drug management and sort of some details there. Okay, so there's also a document that goes over sort of site lead responsibilities in a bit more detail than this, but I wanted to capture sort of, for all intents and purposes, the main things that you guys will be responsible for. So being familiar with the protocol is sort of an obvious one, and part of that is we're going over today. The idea is that you guys will be sort of the site lead fellow, so you should know how the protocol works probably better than anyone, including the site faculty leads, because you're going to be a primary resource. And this is to support recruitment at the site. There's always going to be sort of questions that come up, and you guys will sort of be the point people to ask first. And then sort of obviously Brian, myself, and Keith are sort of backups to that as well. You guys will be able to provide availability. So this is sort of to recruiting fellows to help sort of with logistics of things, answering questions, again, explaining maybe some logistics of the protocol. It is our responsibility as a sort of entire group to confirm patient eligibility. And so this is sort of done in one part, it's done in real time, which we'll get into a little bit later in the talk, with the sort of fellow either during the day or overnight who is actually recruiting the patient. They do sort of a quick eligibility checklist, which for all intents and purposes is reviewing the inclusion and exclusion criteria. But because this is sort of a Health Canada trial and things are regulated very closely, we have to sort of double check to make sure that, yes, the patient actually does meet eligibility criteria. And this is something that needs to be done relatively quickly once the patient's enrolled. And so, for example, there's a couple of different fellows at UHN, but if say this fellow at Sunnybrook isn't there, it's going to be, Brian, myself, or Keith who are going to sort of fill in the gaps to confirm patient eligibility. you guys are going to be able to communicate with the clinical team, which is sort of obvious. The MRP team may have questions about study patients at any time, and sort of they may discuss concerns about keeping a patient enrolled and that sort of thing. Hopefully you guys will be able to speak to the patient if they are able to. If not, then it would be the SDM to answer questions and sort of get consent for the study. And sort of we'll get into this as well, but it's an assumed consent or deferred consent overnight. And then it would be discussing with the family or the patient the next day for if they wanted to withdraw sort of their consent. There's going to be a sort of sign off of applicable study documents. And so we're going to go over this as well, but there's the consent forms, as we mentioned, eligibility, some of the pharmacy documents, and a clinical progress note. Data acquisition is REDCAP, which I know that some of you guys are familiar with. And this is sort of entering the actual patient data for the study into our online database. And Keith will get into that a little bit more. With any Health Canada study or sort of randomized study in general, there's adverse and serious events reporting, which we'll also talk about at the end of this. And then hopefully, if you guys have any concerns with the study, I'm hoping that you guys are able to engage the site faculty leads and as well as us, because we all need to know if there's any study concerns. And then there's going to be an ongoing investigator study file that is sort of a sort of diary log of everything that's happening with the study that we'll be updating sort of together along the way. Okay. So I know you guys have seen a lot of this before, but just a quick recap. So the main objective, as you all know, is to test high dose magnesium with the addition of digoxin as second line treatment versus sort of standard of care, which is amiodarone. And we're looking at rate and rhythm control. We're looking at resolution of critical illness, etc. So the efficacy co-primary outcome is heart rate control less than 110 beats per minute and/or restoration of normal sinus rhythm at 6 hours after randomization, confirmed by 12 lead. And the effectiveness co-primary outcome is ICU-free days at 30 days. And then some secondary objectives. And this, I think, is sort of very exciting for all of us, is this is sort of a fellow-run trial. And this has not really been done before. And I think it's sort of quite exciting for U of T. I know that some centers have done some things run by just fellows, say at TGH, but no one has done a cross-Toronto fellow-run trial. So this would be the first of its kind. And hopefully that if this is successful for all of us, we'll be able to provide some of the groundwork for future fellows that are coming to Toronto to continue studies like this. So I think that's pretty exciting. And because it's run sort of by fellows, ourselves and sort of our colleagues, we've sort of designed everything to be simple, fast, accessible, to be able to be done during the day or on call at night. And we're trying to encourage other fellows to get involved to help us enroll and randomize patients. Okay, some of the secondary outcomes from a more scientific level. So the effectiveness secondary outcomes are mortality at the end of the hospital admission, maintenance of heart rate or rhythm control at 24 hours, continuation of trial intervention at the time of ICU discharge, and presence of new rate or rhythm control medications at first ICU discharge. And then obviously some safety secondary outcomes are serious adverse events. Okay, so recruiting a patient, what happens? So as I sort of alluded to, this is often going to be completed by the MRT Teams fellow, which may be us, but many times it may not be. And often, for some reason, patients only get AFib when people are on call overnight. So it's often going to be the recruiting fellow. Because of that, and sort of it's an emergency situation, there is a deferral of consent model where patients will be officially consented the next day. And this is sort of within the standard of care because AFib is potentially a sort of an emergent arrhythmic situation. And there's going to be a resource information pack available at the central nursing station with all of our documentation in there. Okay, so what generally happens? So the nurse pages the MRP team and says, hey, your patient is in rapid AFib. And they're calling you because they basically want you to come and assess the patient and decide what to do. So this is sort of the usual thing that would happen. I'll show you in the next slide sort of what we all usually do when we're assessing someone with AFib, but it's probably a 20-minute plus assessment when we go through, what medications are they on, what's their electrolytes, what's their fluid status, what are their pressors doing. There's a pretty comprehensive assessment that I think all of us generally do when someone goes into new rapid AFib. So that's our pre-randomization procedures. And I think this is sort of, as I said, within the normal. This isn't anything additional that the clinical trial is asking fellows to do. The next part that is additional, we're hoping is quite streamlined and actually efficient. And once I think fellows have done this more than once, it shouldn't take more than 15 minutes of time, which isn't actually asking a huge amount of time from people on call, is our hope. And so what the on-call fellow or daytime fellow or recruiting fellow would have to do is review the eligibility checklist of a patient to see that they meet inclusion and exclusion criteria. If they do, they sort of would sign their name and check off that eligibility checklist, which is going to be at the nursing station. Then they would enter their patient into our REDCAP randomization website. And there's a QR code to help us sort of quickly get to all this information. They would get a study ID and randomization group info at that point to tell them whether to fill out the order set for the control arm or the intervention arm. Once they know what to do, then they would fill out that order set, which is, again, just check boxes. It's a pre-printed order set. And then after they fill the order set out, for the intervention arm, they would have to log the number of the intervention drug. So this is basically the number of the magnesium vial that's given. And this is just the first dose, the high dose magnesium, because that's the intervention dose. And so you would write the corresponding pharmacy number down in the drug accountability log. And so it really isn't, once people know sort of what they're doing, it's actually quite efficient to, or at least we hope it's quite efficient to actually recruit a fellow or recruit a patient. Okay. So moving on to what the pre-randomization procedures actually are. So this is, again, I think, our usual sort of assessment of patients when they go into new rapid AFib. So if someone is obviously severely hemodynamically compromised, you're going to cardioversion as your usual ACLS standard of care. If there's an offending agent, so say someone is on really, really high dose epinephrine causing arrhythmias and they don't actually need that, you would obviously probably reduce that or switch to another pressor medication. If there's other inciting factors, for example, you just diurese the patient 10 liters by accident, something like that. If their electrolytes are way out of whack, if there's a big pneumonia that obviously hasn't been treated, or the patient is in obvious ventilator dysynchrony, things that you can quick relatively routinely and quickly, you would do all of those things. Usually if the magnesium level is less than 8, as per most of our ICU sort of standard routine magnesium replacements, that would be replaced. And if AFib is still present after sort of all of our usual care, then we would move on to the randomization and the review of the inclusion and exclusion criteria. Okay. So here's all of our inclusion and exclusion criteria. And again, all the resources for this will be at the nursing station and online for you guys to access at any time. So the inclusion criteria is meant to be fairly quick and straightforward. So is the patient admitted to a participating hospital ICU? That's pretty obvious. Do they have a newly documented episode of fast AFib? So they don't necessarily have to go from sinus to AFib. They can go from slow AFib to fast AFib, and that would still count. And it has to be confirmed with the 12 lead. And often the nurses have already done the 12 lead by the time they've called you. The patient needs to undergo telemetry as part of their routine clinical care, which is almost all of our patients anyways. And the treating physician has decided that this is significant enough AFib that they would treat it usually. And I should say they have to meet all of the inclusion criteria. So for our exclusion criteria, they can't meet any of these criteria. So if the patient is less than 18, they're not included. If they have palliative goals of care or are expected to pass away in the next 12 hours, if they've been in fast AFib for more than 48 hours, if they've been treated with digoxin or class 1 or 3 antiarrhythmic in the preceding 24 hours, if they've gotten already some high dose magnesium in the past 2 hours, that would be an obvious confounder. If they have a history of high grade AV block or bradyarrhythmia without pacemaker. So hopefully we would know this. This isn't always possible to find out sort of right in the moment, but any of your cardiac patients, you should usually have this documented somewhere. And if there's any history,
that's a question coming in from Verinder there, and it's a reasonable one, because as you read these exclusion criteria, it's possible to kind of think there's no big hurry, or we're not wanting to get to, we don't care if we get to them early, but we certainly do. The AF for more than 48 hours is essentially still supposed to be untreated, but you've now decided it wants treatment rather than you've tried multiple other treatments. But Virinder's asking specifically about exclusion criteria 3 and saying, where do we time that from? And Verinder, the timing is actually from when it becomes fast AF, when it is above 120. But as I say, we just have to put criteria like that into a trial. But really what we want you to know is we want to get them the first time you see these people going fast, and not say, you know what, it's 48 hours so I can do it in the morning. It's important it's during your first run of treatment. We want to prioritize that or emphasize that to you. Since we've paused, Campbell, we see if other people have questions. I know you're still mid-exclusion criteria there, though.
Yeah, no problem. Okay. Yeah, I think that's it. That's an important clarification, is we want to sort of provide the intervention as soon as possible once someone's in fast AFib. It's not, the plan is not to wait until the next morning, so to speak. Okay, so back to number 7. So some contraindications to one of the study treatments. So this would be to either digoxin, amiodarone, or magnesium. So we have some sort of examples here. So hypertensive disorders of pregnancy, preterm labor, neuromuscular junction disorders like myasthenia gravis, previously documented amiodarone toxicity, or some relative contraindications such as thyroid disease, cirrhosis, pulmonary fibrosis. The relative contraindications would have to be fairly severe. If someone has treated thyroid disease or very mild cirrhosis, that sort of thing, I think we have to take that in the clinical context. But if someone is here with severe cirrhosis or liver failure, that sort of thing, then it may be more or of a difficult decision. So number 8, recent cardiac surgery during the hospital admission, because we expect those patients act a little bit differently, especially if they've had surgery on the myocardium. Known pregnancy, sustained more than 10 continuous seconds documented on a rhythm strip of ventricular arrhythmia in the past 24 hours. Known or suspected pre-excitation syndrome, persistent hyperkalemia more than 6 despite treatment. Is obviously this could be made worse with some of the study drugs. And then previously enrolled in the MAGNAM trial, which is sort of an obvious one, but we have to say it. And then recent lung transplantation during this admission. This will only apply to the group that's recruiting at TGH. But there's a sort of concern of amiodarone use in some of those patients, so we've decided to avoid it. Okay, so I'm going to pass things over to Keith to go through sort of the REDCap database.
Okay, hi guys. So I'm going to run through really just the enrollment part of what would be required for REDCap, because I want you to get a sense of what we are expecting people to be able to do in the moment. And I won't belabor the full details of all the data collection because most of it is actually retrospective. So once everything is set up, you'll receive login instructions or credentials via email. The website is redcap.sunnybrook.ca/redcap, and you'll get a screen like this. Once you log in, Cam will get you to go to the next slide. You'll see something that looks like this, where it says, here are the projects you have access to. You'll click on MAGNAM. And then on the left side of the screen here, you get a view of all of the data collection instruments that are available. And the way you would start adding data for a specific patient is to click add/edit records. Go on to the next slide. When you do that, there will, again, I'm just focusing on the enrollment piece of things, so you won't need to open any existing records for that purpose in the moment. So when the patient goes into AFib and you've just verified the inclusion and exclusion criteria on the paper form, the next step would be then just to click add a new record here. So Ken can go, yep. You get a screen that shows all the instruments. You'd start with the first one, that's eligibility. And basically you get a screen where you'll need to fill out, again, just all of the inclusion and exclusion criteria. They are done on paper before you would go on to REDCap, but we do need to have electronic documentation of this. So it's just a simple yes, no for each one. If you say no to any of the inclusion criteria or yes to any of the exclusion criteria, it will give you a little warning saying, are you sure? And then for each of the, oh, sorry, go back. For each of the forms on REDCap, when you filled out all of the data, you would indicate on this box at the bottom here that's in green that the data is complete. And then you can click save and go to the next form, and that will take you to the next data collection instrument. The next screen is the randomization screen, where you would enter the date and time of randomization, the age of the patient, biological sex, where they're admitted. A few short questions. Are they on vasopressors right now? Are they receiving ventilation? And do you know whether they have chronic atrial fibrillation or not? And this is meant to be, with the information that's currently available at the time, is it known whether this patient has chronic atrial fibrillation? Not go back into, Connecting Ontario and do an in-depth chart review. We need to know the creatinine and whether the patient is known to be of Black ethnicity. That's so that we can calculate their EGFR for the digoxin dosing, as well as you'll have to get the actual body weight sometime within the preceding 24 hours, which can be done on the bed scale while you're assessing the patient. You enter your name and your email address. Go to the next screen, yeah. And then it will ask you whether you would like to randomize the patient. Hopefully we'll click yes. And then when you go to the next screen there, you'll see once you've clicked yes, you get a button that says randomize. Click the randomize button. And it just asks you to verify the stratification variables. This is important. The randomization is going to be stratified by vasopressor use, in other words, shock status, and whether or not the patient is known to have chronic atrial fibrillation. So these details will need to be verified at this point, because once you click the randomize button, they're locked for that record. So then you go ahead and click randomize, and it will say what allocation the patient has been randomized to in a couple of different places. And then I wanted to highlight this last piece, which is that there's an instruction to go to the next form. So you can hit complete on the complete form status here, go to save and go to the next form. And then what you'll actually get is a form that doesn't require any data input, but our objective here is to create something that you can actually print out. So you can go to like Control P or file print this out and actually stick it at the bedside by the patient's bed. So this would contain all of the dosing for the digoxin that's adjusted for EGFR and the patient's weight, as well as the randomization algorithm and the link to the full study documents, as well as a QR code to get there quickly. And so that's basically it. Can go to the next slide there. So these 3 forms are all that need to be done at the time of enrollment. The rest of the data entry happens at various time points retrospectively. And, as the site lead fellows, you would play an instrumental role in collecting those pieces, but for the purpose of sort of time, I won't go through all of that right now. As we onboard each site, we will kind of go over all of what's required for these in depth. But I just want to illustrate this is kind of what we need to do just to enroll patients.
Okay.
Let's pause again then, will we? Thanks, Keith. That's really nice. People's thoughts about that? Questions? Here's another Stefan von During about to join us here. So what do people think about that amount of workload? We've made it as efficient as we possibly can. And you're looking at something you've not seen before, so it's a bit intimidating. What's your gut when you look at that in terms of getting people to do that out of hours? Any thoughts? Alice, what do you think, looking at that?
I mean, no, it looks, I think it's feasible. It just, instead of starting your treatment that you have in mind right away, you delay probably by 10 minutes to do the randomization, right?
That's what we think. Yeah.
I think one of the hardest parts, Alice, as you sort of pointed out, might be convincing people not to do what they usually always do.
Yes.
And not just,
and
ordering whatever.
In the business, sometimes when they say high rate AFib, you just say over the phone, start giving fluids and 2 grams of magnesium. And maybe you don't even go there right away if you're having other stuff going on. So sometimes even 10 minutes might not be super feasible, but it has to be like, if it's in a mindset, it requires, to enter in the mindset, I think.
You raise a good point there, Alice, that there are still things you can do over the phone because we know how busy you are. Just make sure that we're clear you're not giving 5 grams of magnesium over the phone, or indeed an antiarrhythmic. But these pre-randomization things that you were just showing, certainly these are things that you might indeed suggest to give some fluid, for instance. You can indeed do that, but yes, you're going to have to appear at the bedside for sure. Yeah.
In fact, so the 2 grams that I would usually do even before going there, it's something that then does not preclude randomization, right? It's part of the pre-randomization process.
A maximum, yeah. But I guess we'd say to you, we would kind of be keen that that's not your knee jerk, because it's still, we've set a maximum of 2 grams to try to allow you to do it, because we believe it is part of normal practice. But I guess we would probably be keen that you randomize them and try and make the difference between the groups, the magnesium sort of thing. But yes, you can, is the bottom line. Yeah. Other thoughts?
How to decide which patient goes into control arm and which into intervention arm?
That was randomized. Yeah, that's the bit that's random. So
okay, that's.
You didn't see the black box. You just see the black box here, what Keith showed you. But it's actually it was randomizing you, the patient, in this, yeah, and that it was randomizing you here basically. So that's random.
Okay, thank you.
Yeah, so REDCAP will tell you, and you won't decide. Obviously, once you enter all the info, they'll tell you which arm the patient's in.
Yeah, I think that answers Virendra's question as well.
The intervention arm includes amiodarone down there in a red box.
Yes, I'm about to. It's my next slide.
Okay.
So I'm about to go into it. If there's no more questions on the REDCAP stuff. Okay, So this is the two intervention arms. The control and the intervention arm. So I'll just talk about the control first. And so we found that, within sort of standard of care, and what a lot of people usually did was sort of a whole bunch of things. They would give magnesium fluids, Lasix, amiodarone, all sort of at the same time. And so we're trying to tease out sort of what is actually effective and not. We found that many times people would just give amiodarone as well. And so we've decided that our control arm is our usual 150 milligram amiodarone IV bolus, followed by the infusion for 24 hours. And that's where the control arm would stop. So if the MRP team decided that they wanted to continue the patient for a full amiodarone load of 10 grams, that's beyond the scope of the control arm. And the MRP team would have to decide that on their own and for their own clinical reasons and contexts. For the intervention arm, we wanted to first start with a high dose magnesium bolus. So this is 5 grams over 10 minutes. This is the actual Health Canada intervention. And this is sort of the main thing we're looking at. After this, sort of to maintain high levels of magnesium, every 6 hours, patients would get 2 grams of magnesium for 24 hours. And so this would be 5 grams at time 0, and then 6 hours later, they would get their 2 grams. Okay, so they're not getting sort of 7 right away, just to make that clear. Those are separate time points. If the patient is still in fast AFib at 30 minutes to 12 hours after getting the 5 gram bolus, then we would move on to step 2 of the intervention, which is digoxin. So people would get a digoxin load at time 0, at time plus 6 hours and plus 12 hours, and slightly different dosing if the patients have renal failure. And you would know the digoxin dosing already from entering things in REDCAP, because it spits out the doses based on the patient's creatinine and weight. And then if the patients after getting digoxin are still in fast AFib, then we have rescue amiodarone, or so to speak, a crossover, and then patients would get their 150 amiodarone and followed by the infusion. If you've made it to this point where patients are getting amiodarone, still complete the rest of the first box and the second box. So what that means is continue the 2 grams Q6 and continue the rest of the digoxin load. Okay. And then you would still give the amiodarone. If the MRP team again decides they want to continue amio, or they want to continue digoxin and do a digoxin level, they can do all of that, but that's after the 24 hours of the intervention arm. And so that would be outside of the scope of the study. I just wanted to pause there because this is probably an important slide that we all try to understand in the same way.
I have 3 questions.
Sure, please.
Sorry. So
that's okay.
One is the magnesium, we keep giving it independently from magnesium serum levels. Do we
Correct.
measure them, like, or we don't?
No,
like, we measure, but
measure.
we don't care about them.
Yeah, we would measure
Okay.
them as our usual thing that we do in the ICU, but we would give all the magnesium listed here, regardless of the serum level.
Okay.
Alice, they'll not make people toxic with these doses, I can guarantee.
No, yeah, but just, because then the nurses always tell you, so the magnesium is 0.97, so I'm not gonna give the magnesium. So you have to say, no, keep giving it for the study. Okay.
Exactly. That's exactly it.
Then the digoxin, you can decide if to give it right away, like 30 minutes, up to 12 hours. It's your decision.
Yes.
Okay.
Yeah, so that they would have to still be in fast AFib.
Okay.
Right. Or it's sort of like maybe the patient went out of sort of their fast AFib and now they're back in fast AFib, and so the magnesium has not worked or has not worked anymore, then you would proceed to step 2.
Okay. And the last thing that might be like also my very ignorance, but I'm usually less fast in giving amiodarone to people who are in chronic AFib as a rate control medication to avoid any risk of cardioversion, which is very highly improbable in people who are in chronic AFib. But it's not like I usually proceed with all the other things before, all the electrolytes, fluids, magnesium, potassium, calcium, etc. There's no actual risk in doing that, right?
No, we've discussed this sort of extensively with our cardiology colleagues, and there's basically no sort of increased risk with cardioversion in that particular patient group, more than there would be sort of at any other time.
I think just if I'll add to that also that we kind of looked at the literature data, and the literature sort of suggests that this is what a lot of people do, even for patients who have chronic AFib. So we believe this is sort of within the current standard of practice.
Thank you.
Okay. So we can always come back to this, but for the sake of time, I'm just gonna sort of keep.
I have just
moving
a
on.
technical
Sure.
question. Sorry, Cam.
That's okay.
Are you guys aware of any policy of St. Michael's Hospital about magnesium infusion peripherally? Because I was in TN a few weeks ago, and the nurse told me, "Oh, we cannot infuse a bolus of amiodarone peripherally if it exceeds 2 grams." Are you guys aware of that?
I have not heard that, and I have not encountered that at least in med-surg at St. Mike's. I think that if the study is approved, then we should be able to do this in the context of a research study. So I think that's what my response to the nursing team would be. We can clarify with Jan about that, because Jan has reviewed all of this and that hasn't come up for him.
And
No, I was surprised as well, honestly.
I'll ask, and I'll copy you in. I'll ask the pharmacist who's dealing with this at St. Mike's that question next time I email her, because I've already sent her 2 today, so I maybe won't send it right now. Yeah. I will ask that question and I'll copy you in the answer.
Okay, thank you so much. Just every day there is a new update on the policy, so I'm losing track of all of this.
No, it's a good question. Thanks for asking.
Sorry.
I'd be surprised about that, because I'm just thinking of preeclampsia patients for which they usually have peripheral IVs and for which they get huge loads of magnesium. So I'm just surprised about that.
I'm wondering if it was just a neurotrauma ICU for a different reason. It may be possible. So I don't know. I'm wondering if it was just that.
I think Benedetta's talking about amiodarone, though, not magnesium. Are you not?
No. I'm talking about magnesium.
Oh, I beg your pardon. Yeah, right. Stefan is right. Yeah. I'd be very surprised if that was the case, Benedetta, but I will check, because it's funny what policies hospitals have. What the truth is that nurses tell you there's a policy for everything and they can never find them. And
no, exactly.
I always say, yeah, just show me that policy. But they really can.
Yeah, and you know, as I said again, I think in the context of an approved study, I think that should be enough to convince the nurses that this is within our, practice. So
yeah, okay.
I think this is also why we are hoping to have this sign sort of printed and posted up at the bedside, because once it's on paper, that means it's okay.
Yeah. Okay. So I'm just going to move on to go over some of the order sets. So these are what the order sets look like at Sunnybrook. They're just getting approved at that site. And so we'll make similar ones that look sort of as the sort of St. Mike's version or the UHN version, but they'll all essentially be exactly the same as this. So this first order set is the control order set. So this is the amiodarone arm. And you can see that, so it's the MAGNAM trial. We already have the REB number and Brian's name here, so people can call him with all their questions. Obviously, the patient has continuous EEG monitoring, as we said. There's going to be a 12-lead ECG that's performed. You're going to review the pretrial procedures, as we've sort of already said. And then we can give up to the 2 grams of magnesium if the serum level is less than 0.7. Again, this doesn't have to be done, but this would be the maximum, this 2 gram magnesium. And then we would give the amiodarone 150 followed by the infusion. And we have both the rates for a peripheral line or a central line here. And then we just flag this for the MRP team that ongoing antiarrhythmic or anticoagulant considerations are the MRP team's responsibility after the 24 hours. The intervention arm has a little bit more happening. So I've split it over sort of 2 things here. So again, the first part here, the monitoring and general care is the same as the last group. And then there's the magnesium intervention. So this is the 5 gram IV push over 10 minutes. And there's 2 different preparations that can be provided here. This will be from a sort of lock and key stored pharmacy room, because this is the Health Canada sort of clinical trial intervention. And then everything else after this is sort of the usual magnesium from the regular pharmacy stores, not the Health Canada magnesium drug. So this is your usual 2 grams over 30 minutes Q6H following that rapid infusion. And then these next boxes wouldn't be filled out without the nurse paging you or you realizing that the patient is now back in AFib. Because we wouldn't want the nurses to just give all of these medications without an actual clinical indication. So it's if the patient's back in AFib, then you would fill in your digoxin dosing that you get from REDCAP. And then if they have renal function, that's this second box here, number 10. This is the first box is their regular dosing. And then if they're still in rapid AFib, as we mentioned, as per the protocol, then we're moving on down here to amiodarone. And this is, again, your 150 bolus here, and then you're either peripheral or central line infusions. And same thing as the control order set. We've just said all antiarrhythmics and anticoagulants after this are the responsibility of the MRP team. Are there any questions there? This is basically the diagram that we showed you. It's just written down in the order set for the bedside nursing team to follow. But it's essentially the exact same thing we just showed you in the intervention treatment diagram.
Sorry, yes, sorry. I'm very annoying. I have another question. For the patients in the amiodarone group, can they receive magnesium? Or are we, I don't know, is there an indication of keep serum magnesium above 0.8? Or do they receive upon clinical indication only?
Yeah, I think our suggestion there is that if it's less than 0.7, then we would you can give the 2 grams of magnesium.
Not before enrolling, also after, when they are on the amiodarone infusion.
Yeah, I think
before enrolling, I understood what you meant, but in general, in their clinical course, is there any limitation in the amount of magnesium they can receive?
So the only limitation is that we wouldn't want it super therapeutic, right? So we would only, you know how some people sometimes change their, target amiodarone more than 1. We just target magnesium levels. So you wouldn't target more than 1. You would target your normal magnesium level more than 0.7, which is your usual ICU replacement. Does that make sense with everyone?
I would just add that the amiodarone infusion goes for 24 hours. So if you enroll someone and you give them 2 grams as you're enrolling them of MAG, we think that for most patients, you probably wouldn't measure their extended electrolytes again until the next morning or so, and at that point they might be out of the amiodarone group, so you wouldn't treat them again unless they are, below that serum level. And then what happens after that 24 hours is sort of up to the clinical team.
Yeah, the exception there might be at the Western, where there's lots of salt problems and they're doing electrolytes, every 10 minutes, or realistically every 4 to 6 hours. But, other than that site, usually they'll just do a once a day check and then nurses will replace based on that. So it probably won't be a huge sort of controversy. Okay, and then so sort of after the order set's done, or sort of alongside the order set, there is going to be a drug accountability log. And so this is just filling out this is just that first dose of magnesium, the 5 gram rapid infusion that's from the Health Canada stores, filling out, which exact bag was used for what patient, basically. And so it's just so we keep track of, patient study number this got this lot and this bag of magnesium. And so these logs would be kept, I would assume, with our box of magnesium at each site.
Is this going to be filled in by the nursing team or by us?
This would be filled in by you guys, I would think.
So this is a good question, Stefan, and it's an important one. It might be something that you site lead have to check is being done, but it is important that we get this documented. So it might just be hard to get the nighttime fellow and the nighttime nurse to fill this in, but we would ask them to fill it in, but you to quality control that, basically. So if a patient's been recruited, you'd want to go down and just make sure you've worked out that, they've taken the drug from the right place, the box smart MAGNAM, which will be a lock box, and this paper will be in the box and should be completed. So if it's not, you'd have to assure it was completed.
And this box will be in the pharmacy, right?
No, well, it depends what you mean by the pharmacy. It'll be in the drug room in the ICU.
Oh, got it. Okay, not downstairs like in a pharmacy.
No.
Okay.
So it will be in the clinical room in each clinical area. So for instance, for Sunnybrook, there'll be one in the CRCU room that will cover CV and CR. There'll be one in D5 and one in D4.
Okay, perfect. Got it.
At St. Mike's, there'll be one in TN and ICU. At TN, I get my initials mixed up, but one in the 2 main ICUs.
TN and MedSurg, yeah.
So there'll be one in each major unit, basically, a lockbox with a code password. I just bought them today, and this document here. So yeah, we would ask that they fill it in when they take it out, but you'll have to double check it's done as your part of your next day sort of duties, and that's how it will work. Someone's recruiting the night, you'll get an email. We just ask that you go check the patient, make sure the right things have been done, make sure that this is documented. Yeah.
Okay, so that sort of leads us nicely into after recruiting a patient, what happens. And so part of it, as Brian just mentioned, was the sort of quality control of making sure, double checking the patient was eligible, making sure the drug accountability log was filled out, and then a couple other things here as well. So this is obtaining consent for the study. And again, we'll have a standardized consent form, which we'll share with you on our online resources. And then documenting that. And then alongside that, there will be a clinical note written in the chart that just says, we'll provide a template for this as well, but it's basically as the saying the patient has been enrolled in the MAGNAM study, this is the arm, et cetera, et cetera. And then there is some data entering that will go into REDCAP, which is sort of what Keith pointed out. And then ongoing for the sort of duration of the patient, that's duration of the study time, we'll be keeping our eyes out for adverse and serious adverse events. So I'll just move on to this next slide to go over that. So these are standard Health Canada definitions for sort of serious or just serious adverse events and just adverse events. And they're based on sort of the Health Canada product monographs, which we also have those listed on our online resources that we will share with you guys. And it's sort of, I mean, the examples are a serious adverse event for amiodarone could be, you know, cardiac arrest or arrhythmia. And, you know, you would if something like that happens, you would double check that that's one of the things listed on the product monograph for amiodarone, and then we would flag it as a serious adverse event. Oftentimes people over-report these kinds of things, but, you know, it's always important to, I think, discuss with the site lead or us as well, if we're not sure whether to record or report this. This is our sort of general diagram. So if it's a not serious event that happens and you don't think it's related to any of the study drugs or whichever arm they're in, then this is obviously something you wouldn't report. If you do think it's possibly or definitely related to any of the study drugs, then you would complete the adverse event log. And same thing for serious adverse events. So if you don't think it's related, it's not listed in any of the product monographs as a side effect, then you wouldn't report it. And if it is, and you think it's related to the drug, then you would report that. For serious adverse events, they want you to further delineate things into expected and unexpected reactions. And these are sort of part of the adverse event log. Are there any questions on that? It's a little bit easier once you guys, or once we review the actual drug monographs, and so you see what's listed by Health Canada, for example, for amiodarone, for digoxin, etc. And this is not something that has to be memorized. It's going to be provided as resourced, obviously.
And remember, folks, there'll be a pack that you'll get when you start to review a patient's eligibility at the desk, as Cam mentioned earlier. But in that will be all these key papers. And I think you saw the QR code on one of the documents that, for instance, the randomization document, which leads you to the SharePoint files. So all these documents will be hopefully at your fingertips so that you can refer to them in real time rather than trying to carry them around in your brain. And that, so hopefully that will work well for you. In Sunnybrook and hopefully other centres, we'll also have a directory on each desktop around the units, all units, where you will be able to have a MAGNAM directory that all the stuff will be as well. So I'll try and achieve that in other centres.
Okay, so what do our timelines look like? So we're getting quite close to starting recruitment. The planned start time for the Sunnybrook site is December 1st. The other sites, UHN and St. Mike's, it's hopefully going to be January. There's a little bit delay in terms of sort of legal and that sort of things, but our hope and plan, and sort of as we see things now, it's for January. So everything we're sort of trying to do now is all a little bit time sensitive. And then our recruitment period is about 12 to 24 months, depending on how many patients we get recruited. And we need about 200 across all the sites. So, you know, we really don't think that it's going to be a huge work burden between all of us together, working between all the different sites. So I know it may sound like a lot, but I think that it actually will be very manageable on top of all of our clinical stuff.
What dropout rate are you guys anticipating?
What do you mean dropout, Stefan?
Yeah. Because people are going to be randomized before getting consent, right? So how many people do we think are going to have consent withdrawn once they're randomized?
Not too many, I think you'll find. Certainly with in Sudoku, for instance, that you know well, our refusal of randomization rates really very low. I think when you told them you've done two things that are within the standard of care, both treatment arms here are within the standard of care, and you've already done it, then I think the chance they're going to turn around and object to the principle of it and is not high. And you would, even if they said, if you said, look, I don't want to be part of your trial anymore, you go, fine, it's already done, and there's no follow-up for the patient, etc. So, and only if they specifically say, not only do I not want any more to do with your trial, but I want you to remove all my data, do they get taken out of the trial? That's all approved by ethics. And therefore, I think the loss to follow-up rate will be at most 5%. Loss because of consent. In Sudoku, it's actually sitting at about 2%.
Okay. So we only have a couple more slides, so hopefully we don't take too much more of your time. Thanks for everyone for sticking around. So for sort of recruiting other fellows, or the daytime or on-call fellows to help with this, we need to start sort of approaching our colleagues at each of the hospital sites to sort of engage them in the study and let them know about this. We've done a couple half days, so I think a lot of people do know what's happening, but not everyone may know that this is sort of imminently happening at each site. So we're looking for you guys to speak to your colleagues at your respective sites, UHN, St. Mike, Sunnybrook, and Keith and I will sort of liaise with U of T fellows who are rotating around all the sites, because they're obviously not in one spot. We have lots of resources which we will share, including PowerPoints and all sort of our slides for explanations and getting people on board. We're open to any of your ideas about how to convince people to be part of our group and help us sort of accomplish this. And then we need, if fellows are sort of recruiting people, we need them to be signed off on the modified task delegation log before they do anything for the trial. And we'd have them watch parts of this video, so they're, so to speak, trained on certain things. Okay, and I'm going to pass things over to Brian to talk about some of the Health Canada stuff.
Yeah, so thanks, folks. So I'm very, very excited about this and delighted that you're here on a Friday evening. Sorry to take your evening. I'm not going to take much more of your time. This is a really exciting opportunity. But folks, this is a Health Canada trial. And a Health Canada trial is a regulated trial with a high level of oversight from Health Canada, including auditing and other such things. This is all within drug law within Canada. And so I want to emphasize to you just how important it is that you realize that basically magnesium for this trial now as the IP, investigational product, is treated with the same legal deference as a controlled drug. So we must not swap ampoules, use ampoules in different patients, fail to document what we've done with the ampoules, etc. All the stuff we're showing you here, I'm afraid, is necessary. Everything that's not necessary has been cut out of this. We cannot cut corners. We can't do things in a sloppy fashion, I'm afraid. We have to do things properly. So I'm going to ask that you keep a good oversight of the fellows in your unit. So for instance, if you come in the morning, find a patient's been recruited and they haven't had the appropriate things done, you need to engage with that fellow in real time, please. And speak to them about that. Speak to us. We'll help support you, etc. We'll help answer your questions. But we really need to treat this with the highest level of seriousness and rigor throughout. I make the point there, and it's actually not a joke. Ultimately, PIs, that's me, can go to jail and for offences to this, because this is against the law of the land. That's just to emphasize the severity. So we need to do this well, be thorough and rigorous. We don't do anything with the drug we shouldn't do. Any drug that's not used has to be kept. Any drugs that's used can be disposed of, but we need to know the numbers and then log it on the sheets, as we've said. We need to fill in the database accurately. We need to follow the protocol accurately. So we can't just say, you know what, I'm just giving amiodarone now because we've not yet given digoxin, for instance. That's a protocol violation and it has to be reported. So really important that we really stick to the rules, and you need to get that over to your fellow colleagues. Remember, there's carrots for them. I think we're still got a final mention of the authorship policy. There's carrots for everybody here. For you guys, it's authorship for appropriate contributions in line with this, and for the fellows, it will be being part of the broader trial group, which does get them on PubMed as well. So hopefully the carrots are good enough to warrant it, but the rigor here has to be of the highest level. Thank you, Cam.
Okay, thanks. No problem. Okay, so you guys will all get access to all the study documents on SharePoint. And this has, as we said, the manual of procedures, the pharmacy stuff, product monographs, the protocol, et cetera, et cetera. And if there's anything that's not here, just let us know, but I am pretty sure all of the documents and resources are going to be shared here. And then Brian already sort of explained the authorship, and I know I had sent this policy to you guys in email at some point, but you guys will all gain main authorship on the paper for being a site lead fellow. And the recruiting fellows, if they recruit, and I think we decided more than 3 patients into the study, they will become part of the MAGNAM trials group, and they will be listed on PubMed. And so it does count for them as a PubMed publication as well. And again, this is sort of the idea is that this research comes out of the fellows group, the international and the U of T fellows all together at U of T, and it would be sort of the first of its kind. So I think that is a quite exciting thing. Okay, and if there's any questions, or if you guys want to sort of sit and think about things and email us, or you can all text me for questions after. I'm happy to let you guys get to your Friday night plans, but happy to answer questions before then too.
Just to mention, Verinder had some good questions in the chat here. One about whether we would be able to recruit patients before they're actually in the study ICU, to which I've answered that because all the study documents and the nurses who are involved in doing this will be in the ICUs, we can't actually recruit anyone outside of our study ICUs.
Yeah, and usually those patients wouldn't be on telemetry. That's not true everywhere, but in most cases, that would be an exclusion that they would miss, or an inclusion that they would miss, sorry.
And then there's another question here, just is there a provision to hold amiodarone if the heart rate became less than 60 in those without prior bradyarrhythmia history?
I don't think so.
Well, so we're clear. The clinicians can do whatever they want if they're unhappy with the drug treatment, including stopping and holding it. What they can do is shuffle the order or omit things unless there's a clinical indication. But if this happens, then yeah, they stop it. We haven't protocolized that. Everything within here is still within the governance of the SDM. Sorry, the MRP. Only feels like it's
sometimes the SDM. and just to point out that there is a section in the REDCap database, so if there are things like this that do come up, you can describe this as sort of a unplanned deviation that we needed to stop this because of XYZ, and that's something that we would report afterwards.
I got you.
And with and we'd think, is this a serious adverse event or adverse event that caused a protocol deviation?
This is why I asked for cell phone numbers, guys, and I hope you don't mind that. But as far as I'm concerned, and I think Cam and Keith are the same, you're not sure, you text us. We communicate in real time with texting if it's something that indeed needs that sort of responsiveness. But we don't say, you know what, I'll deal with this in the morning if you're worried about something significant. But again, the clinical message is the clinical team do the safe thing every time. But it can't be just at the whim of the clinical team. It must be because of an indication that we could write down as the reason for a protocol violation or something similar, yeah?
I had a question. I heard that there are QR codes. Does it mean that we'd be able to scan with our smartphone the patient's QR code and access the REDCap and actually fill it in at bedside from a smartphone?
You can certainly use REDCap on your phone, although I will say the interface is not terribly mobile friendly. The QR code goes to the SharePoint. So we just wanted to make sure all the study documents were available for easy reference. I think if you guys think it's helpful, we can generate another one that points to our REDCap database, but having tried to access it on mobile, I will say you probably will end up using a computer in the ICU.
So it's not an individual QR code per patient.
No.
Got it.
No.
That's what I then, perfect. Then I got it. Thanks.
You made us feel bad now.
That's what I put in my RCT protocol for my course.
You're still just talking about it to us, Stefan, I know. All right.
Okay, well, thanks, guys. We're really excited to have all of you guys working with us. It should be great. And yeah, hopefully we'll
This is
be
a
able
really
to-
nice project. So thanks, everyone.
No problem. Hopefully at some point we can get together and celebrate with Italian food and drinks, of course.
We seem to have quite an Italian sort of movement going on this trial.
Yes.
I was in Italy just a few weeks ago, so I love Italy. So, and I suspect we've got at least 2 Italians and someone who borders on Italy at least in our group. So
Yes.
yeah, let's make a point of getting out soon, my treat, and I look forward to meeting you in person.
Great. Okay, guys, enjoy
Thank
your
you
Friday
so
night.
much.
Thanks so much.
Thank you.
Thank you so much.
Bye-bye.